So Dr. Morissette is a physician since 1978. He's been a psychiatrist since 1983 and certified in forensic psychiatry since 2013. Since 1993, he's worked as a psychiatrist at the Philippe Pinel Institute at the prison as well, and has worked in the community office and in community hospital. He's an expert in criminal, civil, youth, family, administrative, and disciplinary courts. And he's a clinical assistant professor in the Université de Montréal Department of Psychiatry, as well as author of some scientific articles and book chapters. He's also a member of the board of the Canadian Academy of Law and Psychiatry and a secretary of the Quebec section of this organization. And Dr. Morissette is going to talk today on the consent and the capacity at the end of life. So, Dr. Morissette.
So thank you. Thank you for being here. I would like also to thank Dr. Ferrier, Charmine, and all the volunteers that have made this day possible. They took a lot of time. Bear with me because English is not my first language, and the terms in English do not come easily to my mind. So I have I have no financial interest, but you can presume, and you would be right, that I am completely, since the beginning, against the concept of euthanasia. So in that sense, I'm biased. The learning objectives are to know more about what are the legal obligations of the physician for fitness in these circumstances, the criteria to be fit to consent, and to know, and maybe to show some scales that can be used if we want to use them to evaluate fitness and capacity to consent. So fitness is every adult is usually presumed fit to drive, to write a will, to request medical aid in dying. So usually it's presumed. In medicine, if someone asks for something, he is usually presumed to be fit. It's very task specific. Have to be fit to drive, fit to write a will, fit to write a contract, fit to marry, whatever, and at a specific time and in a specific context. So medical aid in dying is very specific. And when we talk about fitness, we have to talk, the terms can be interchanged, fitness and capacity. So fitness to stand trial, there are criteria in the criminal code. To accept or refuse treatment, to write a will, like I said. Consent, in French, we say libre et éclairé. So in English, would be with free will and with knowledge. How do you say éclairé?
Informed.
Informed, but to be informed, you need information. You need to be given the information, and you need to understand and be able to manipulate in your mind the information. And this phrase comes from the Collège of Physicians of Quebec about medical aid in dying. Since the more important the treatment, the consequence, more important the consequence, more knowledge is required. So you have to be in the circumstances of MAID. You have to give a lot of information. It's an obligation. Like I said, usually if I go for a hip replacement and the doctor gives me the information, he will presume that I'm fit to say yes or no. If a patient requests a MAID, he's not presumed to be fit. It's an exception, and he's not presumed to be fit. And it's the same, well, all across Canada and in the US. So the doctor has to be sure that the patient, the doctor has to evaluate fitness. It's not presumed. And some doctors would like that to be taken away from the law. In the law here now, you have 3 moments where the patient has to be evaluated for fitness. At the first request, the second request, and at the right before the event, right before the injection. So in theory, there are 3 moments where in the file you should find patient is fit because, yes, you have to write because of this, because it's not presumed. You need to have a direct discussion. It's not tacit acceptance. If the person cannot talk, then you need a written signature and written acknowledgement from the patient. So how do we evaluate fitness or capacity? Like I said before, it's a mental at specific time for a specific task, and there are 4 cognitive skills required. The first one is comprehension of information, the Nova Scotia criteria. Do you know about these criteria? A bit, I guess. I know a bit about them because I had to testify in Court of Appeal in 1994, and we brought that to the Court of Appeal, and since then it has been used in Quebec for consent, but it was at the time used for psychiatric patients who refused treatment. But it's the same that we can use. So the first one is, do the person know what kind of illness or treatment is suggested? Why the treatment is suggested, the side effects of the treatment, what would happen if the treatment is not offered, and does the illness affect the ability of the patient to comprehend all the information? Usually, when I use these criteria for psychiatric patients, it's the last item that is not working. They know we are saying to them they are schizophrenic. They know we want them to take antipsychotic medication. They know that the medication would have side effects, and they know that if the psychosis, they hear that the psychosis, if not treated, could bring them back to the hospital or suicide or whatever. They know all that, but they say, doctor, I understand what you're saying, but I'm not ill. I don't have that illness, denial. So, and then the second cognitive skill is the same as the last criteria for Nova Scotia, the criteria of Nova Scotia is self-awareness. Are they able to apply to themselves the information that we are giving them? Can they compare risk and benefits? Can they communicate their decision, and are they able to show us the reasoning they are employing? Let's say someone says, yes, I want to take the medication, and in the afternoon they refuse the medication, and 3 days later they, okay, I'll take a dose, and a week later they stop again. That's not constant. Then we'll go to court for the patient to be declared not fit to accept this medication, and he will be forced to take the medication. So in MAID, we have to be sure, and that's why I think in the law there are 3 moments where the fitness has to be evaluated. So these are the cognitive skills. But there are more obstacles to consent. I think one of the obstacles is are we talking about sedation, palliative sedation? Are we talking about making the pain less present? Are we talking about double effect? I think people do not understand everything all the time. And sometimes they don't know about the options, who are either not mentioned or not available. I think there are sometimes bias from the doctor himself because of his beliefs. The knowledge will come back, and again, like I said, the availability of options. If you yes, you can. You could ask for. You can ask. You have the right to ask for MAID, but do you know there are other options? Ah, no. Tell me about them. Yes, I can tell you about them, but they are not available in your region. So that's not free will. That's not with knowledge. The evaluator. The first clinician may have his own bias, but it's tough for the second evaluator, because if the second evaluator is a younger doctor who is just starting his practice with his director who did the first evaluation, how is the second doctor is going to contradict, not be of the same opinion than his senior colleague? That's tough, you know. You work in the same hospital, in the same department, and it can be difficult sometimes. And also a physician who has both clinical duties and administrative duties. He has budget in his mind, and he has clinical obligation, but he has budget. I think it has been said before that if you strictly look at numbers and dollars, MAID can be a good thing from that perspective. Also, the question of identification to the patient family or to the patient himself. Every situation of a dying person is difficult. Difficult on the person himself, difficult in the family, difficult for the treating team. It's sad stories. It's never good. It's never a good thing. So you don't want to see that. So if you can make it disappear fast, that can interfere with your judgment too, or how you will evaluate fitness. At the end of life, there are delirium up to 80% of cases, anxiety disorder up to 30% of situations. Depressive symptoms, it may vary between 5 and 26. Other studies, 8 to 47. Insomnia. So, and sometimes it's under-identified. And how can the depressive symptoms interfere with the ability to see different things? People suffering from depressive symptomatology, patients, would be more likely to ask for euthanasia. It has been shown 50% versus 8%. It increases the request by 25% or 4 times, because depressive symptomatology bring cognitive distortions, hopelessness. You know all that, most likely. Negative rheumatology cannot be better. I'm suffering. I will always suffer. I'm dying. I want to end it sooner. It's not worth it. My family has to come every day. They have to pay parking. Why put that on them? So you get into negative thinking, and it can interfere with the ability to make a choice. There's also psychological pain. I'll come back later on about that, but psychological pain is not only a philosophical concept. It can be evaluated. There are scales about that. So pain, guilt, humiliation, loneliness, fear, anguish, hopelessness, these can be evaluated. There are questions and scales that you can use, and they are quite potent to evaluate in everyday life. When we use these scales, they are quite potent to evaluate suicidal risk. In Oregon, studies of Gansini showed that out of 47 people who accept to go through the research, 72% refused, but so 40 patients accepted. They had been given the pills already. they were home with the pills, and 25 had clearly clinical depression that needed to be treated. And from the evaluation, they said at least 3% were unfit to take or not the pills at the time when they made the interview. And when persistent depression, last year there was a presentation about depression and how can you help depression, depression that do not respond to usual treatment. Well, pain has something to do. We heard Dr. Vinay talk about that. Ketamine is more reserved, but ketamine is the next drug in psychiatry for treatment of severe depression, and it works very, very, very well. It's difficult to give. IV, it's not easy to give, but the research is very clear. It works on a short-term basis. Now they have to develop ketamine that will have a longer duration of action, but it works very well. Psychostimulants, Ritalin, or things, transcranial stimulation. It's not as effective as ketamine, but it can be used, and it's not invasive. It's just like earphones, big earphones that you put on the brain, 20 minutes, 40 minutes, 2-3 times a day. And for some patients, not 60%, but 30 to 40 patients, it does alleviate depression and anxiety. And it doesn't do any damage. So that's a nice thing about it. It's available at different places, but it's a research center. At CHUM they have it. Most likely they have it at the Douglas also. Some psychologists use it in their office. And the older medication that we don't use anymore, Elavil, Cinequan, Doxepin, these are medications that are used in palliative care, but maybe they could be used more. Like I said before, if someone is depressed and treated, they will request less MAID. They can change their MAID. How do we evaluate depression? There are many, many, many scales. I took 2 just to give you examples. It's possible. It's not very complicated. The point is not to read all that and to learn them. You need the papers, but my point is to show, and these can be used on a day-to-day basis or a week-to-week basis. So it gives you, you have a number at the end, and then someone has 16, and 3 days later he has 21, something changed. And if the third one is still 21, 22, you can change your treatment. So you can use, and it takes less than 10 minutes to go through the scale. That's 2-page scale. And when you have suicidal ideation, is it the context? Is it depression or pain? Is it negotiation? If you cannot stop the pain, I want to die, I want to kill myself. We hear it outside of the MAID context. We hear it in the Clinique de la Douleur, pain clinic. So suicidal ideation is a sign of something. We talked about pain, for sure physical, psychological, existential, spiritual. And how is it possible to evaluate pain outside of physical pain? It's necessary in our field, especially in the MAID context, to evaluate. It's feasible, but this kind of evaluation takes a bit more time than depression. So one scale is the psychic scale. Yes, the point is not to read, we cannot read them, but it exists. You have it with you, you score it, and you get a number. And if you get research has clearly shown that if you get more than 27, the suicidal risk is high, and it's a better predictor of suicide than the Beck depression and Beck hopelessness, which are 2 scales that are regularly used for that purpose. So this one is better. but it's not used very often. Another scale would be the Me-Bernice psychological pain scale. The same, it takes not a long time. It takes just a few minutes to write the thing, but you have to talk with the person. So that takes a bit more time, maybe 10, 15 minutes. And then if you get a score of more than 32, it's a sign or a very high risks for suicide and depression. It's more precise than many other scales that we use. End-of-life cognitive capacity. There are research that shows that there are people at the end of life, so cancer or whatever illness, there's diminished decision-making capacity. There are research will show between 40 and 70%. 40% of 200 did not have capacity for a cognitive reason. So how do we evaluate capacity? You know the mini-mental. Again, when I use that at least once a week, but I don't know it by heart, so I need the paper every time. But I have the paper and I check this, and it does help. There are ways to evaluate, or you can use the MOCA. It's more sensitive. Again, another tool for evaluation of capacity and fitness. ACE, Aid to Capacity Evaluation, MacArthur, and there's a tool, a publication from the Collège of the Surgeons of Quebec that was published in September 2018. It's very well done. So ACE was developed mainly in Ontario. So it's longer to do if you write it, but it's the same process. Do they know what they are suggesting to them? Do they know the side effects? Do they know, in this case, that it's you cannot come back? So you go through that. So there are tools to evaluate. MacArthur, it was developed for research and treatment. This one is for treatment. So you have to understand what are the alternatives. But again, the alternatives have to be available. If you say, well, we could give you this, let's say medication, we could give you maybe medication like methadone to alleviate the pain, but we don't have a methadone. So is it consent with knowledge? And then, do the person suffer from anxiety or depressive symptomatology that may interfere with their ability to see hope or to see that their situation can improve? So the depression scales or that we saw earlier, can they think about the information we are giving them? Can they express to us how they come to their conclusion, and are they able to express a choice, clear choice, more than just yes, and then we don't know what they say. So they have to repeat at least 3 times that they want the treatment. Well, no, that they want the medication. It takes time to evaluate fitness, either for fitness to drive or fitness to stand trial or fitness to write a will. It takes more than 2 minutes. It takes 5, 10, 12 minutes. And there's no emergency. You have to take the time. It's not soin à la carte. Dr. Robert du Collège des médecins mentionnait que c'était pas un soin à la carte. It's not only that you request it that you will get it. There's more to it, and we have to be sure that it's a request that is clearly desired, and not because there are no other options. The organism that gives credits for McGill, the McGill organization that gives credits for medical evaluation, they ask for this article to be used, saying that, look, there's no depression for people who are requesting euthanasia. But it's not what the article says. The article says, according to the depression subscales of the Hospital Anxiety and Depression Scale, 47% of the patients who explicitly requested euthanasia versus 28 of those without an euthanasia request suffer from a depressive mood at inclusion. But at the end of the article, they say that they have depression has nothing to do with the request. The request for MAID has to be free, with knowledge. It takes time. The doctor must know himself and must know what the obstacles can be in the patients to have a clear mind and the ability to decide, and the options must be available. So it takes education, training, financial choices. For example, ketamine is a drug that costs money, difficult to use, but also costs more than methadone, for example. And my last point is, someone watching is, we heard this week the results of the Commission de Surveillance, and they talk, well, from the papers, I didn't see the complete report, but from what I read in the papers is that they give the numbers of requests. They also insist on the fact that many patients seems to be asking and not receiving because of different factors. But in the law, if you look in the law, and if you look on the papers that have to be filled by the doctor, nobody is telling us if the question of fitness to be able to ask is there for the patients. Nobody is watching. That's a bit scary for me. And also in the report, they didn't say, they insist on why did the patients did not receive what they were requested, but they don't insist, is there a palliative care available? Is there home care available? Is there other options that are offered and available? So that would be what I have to say. Do you have questions?